For everyone interested in NASH or more broadly fatty liver disease, surf's up because the first day digital ILC summary from Surfing the NASH Tsunami starts now. So this episode is going to be different for a few ways. We have no music at the end. We have people giving individual reports on article or presentations of interest. And we're going to try to keep this whole thing to a really crisp hour because we know that you've been with this meeting for a long time already. If you're in India, it's 8:30 the next morning. If you're in LA, it's 8 o'clock tonight. But for most people, it's going to be in the middle of the night. They will have been through day one and they'll be headed into day two. So we're going to try to keep it relatively quick. We have one guest with us each day. Today, our guest is Naim Alkhouri, who you all met on episode 15, which turns out to be, at this point, the best, most listened to episode in the history of the podcast. Everyone who was part of episode 15, congratulations, including you, Naim. Everyone who's part of episode 15, congratulations, including you, Naim. Okay. With that, we're going to get started. We're going to use a different question than the one we usually use. Today, our first question will be, what was the most important thing you think you heard or saw happen today?
I'll start. I think the most important thing was that EASL did succeed in translating such a complex, complicated, multifaceted meeting into a digital context. For all the sessions that I saw went tremendously smoothly. And they even gave, a little virtual nod to the, to having a community hub and all those pieces. And so I think just congratulations to EASL for standing this meeting up for everybody to be able to access all this fantastic science that, has just been waiting for a forum to emerge.
And waiting. Yeah, I agree. Amen to that. Next.
Louise here. I'll go next. Mine was listening into the Intersect session symposia this evening, where they were concentrating on primary care and American primary care physicians, that 31% of basically physicians didn't know that Nafl was a problem, which did shock me. So that was probably the most shocking thing I heard today, and which shouldn't surprise me after several of the podcasts that we've done.
Stephen, don't be shy.
Yeah, I think, the most interesting thing I heard, and when I mean interesting, I mean, for me, information that I can take and apply either to my clinical patients or to NASH therapeutic clinical trial development. There was a lot of data focused around FIB4. The prediction of severe or progressive liver disease using FIB4 is there, and there's more data linking that. The problem is most patients that develop liver outcomes have a low score at baseline. Half of the patient events occurred in patients with low scores at both tests. So if you tested FIB4 at time point A and tested it at time point B, half of the events occurred in patients that had low scores both times. And then patients with improving scores still had more events, not less. And overall, the positive predictive value for outcomes was very low, especially in an unselected patient population. So we use FIB4 a lot. I think the data just isn't that helpful with FIB4. That's what I took away from today that I thought was most interesting.
Peter, Naim, go ahead.
I'm always looking for, class effects across different agents that are being used for NASH. And of course, FXR agonists are one of the most important agents, with obeticholic acid kind of taking the lead. But there has been a lot of promise put forward about the potential for non-steroidal FXR agonists that may work better or may have fewer adverse effects than obeticholic acid. I was interested in the study on nitazoxanide in NASH, And there were a couple things in that study that stood out to me. One that I'll just leave with you here is that it had a very high incidence of pruritus, which was one of those things that it was hoped that non-steroidal FXR agonists might not have. So that the high dose, they had 54% incidence and 30% in the lower dose. Therefore, suggesting that class of FXR agonists may not have as many differences as hoped. There are other important issues in that study, but that was one that stood out to me as kind of a hope of non-steroidal FXR agonists that might not pan out.
Okay, thanks. Peter, Naim?
I was impressed with data on the non-hepatic complications of Nafl NASH when it comes to non-hepatic cancers, other complications related to diabetes, cardiovascular outcomes. And I think this is going to play a role in drug development because these are very important outcomes that we need to really account for in clinical trials and clinical trial design. When it comes to, for example, development of diabetes, utilizing medications like GLP-1 agonist, that might be attractive even in non-diabetics if you can actually prevent development of diabetes later on. So I thought this was interesting. There was data presented on non-hepatic cancers and the burden of liver cancer in terms of mortality in patients with NASH, and I think that was an eye-opener for me as well.
I'm in the same place you are. As a forecaster, the single thing that struck me most was from the U.S. Registry paper that I think you're going to be talking about, Naim, about how much more liver death was associated with Nafl than cardiovascular death, right? Because the talk has always been that the leading cause of death in people with Nafl is cardiovascular disease. This registry clearly showed something very, very different. And we're going to have to digest what all that means. But it's the flip side of what you're talking about. Take all the work you're doing on developing liver drugs that also deal with these issues, turn 45 to 80 degrees to the left, and work on a whole different set of accompanying issues. I thought that was hugely. So with that to start, what we are going to do next is we are going to go one at a time through the various papers that each of us signed on to cover today. Naim, if you don't mind, since we kind of ended on the paper that you're covering, why don't you please start us off?
Hi, I am Dr. Naim Alkhouri, the Director of the Fatty Liver Program and VP of Academic Affairs at Arizona Liver Health in Phoenix, Arizona. I have been involved in NASH clinical research for the past 13 years, including epidemiology research to understand the natural history of the disease, the development of new biomarkers for NASH and fibrosis, and most importantly, clinical trials of new therapeutic agents for NASH. I chose abstract 157 today with the title Liver Disease Progression and Clinical Outcomes in the Hepatic Outcomes and Survival Fatty Liver Registry, or what we call the Hot Surfer Registry. Very interesting name given the fact that we are presenting as part of the NASH Tsunami podcast. This was presented by Dr. Blaise Kutula on behalf of the co-authors. So as a background, in patients with the full spectrum of NAFLD, the incidence of liver-related morbidity and mortality is not actually well defined. We have several studies that demonstrated that patients with advanced fibrosis, defined as bridging fibrosis or cirrhosis based on the NASH CRN staging system, have increased liver and overall mortality. But less is known about patients with less advanced disease, and especially those with type 2 diabetes and the impact of diabetes on the natural history of the disease. So the Hepatic Outcomes and Survival Fatty Liver Registry, or Hot Surfer, is an international registry, has 8 centers in Europe and Australia, and they followed consecutive patients that received liver biopsy for suspected NAFLD between 2004 and 2011. And they collected data on liver-related outcomes and overall survival. So at the International Liver Congress, Dr. Blaise Kutula presented data on the first cohort of subjects that were enrolled in the registry. Patients were followed for approximately 10 years after the index biopsy. Liver fibrosis severity was determined using a new 7-point staging system called the EPOS system, which stands for the European Project on Steatohepatitis Staging System for Fibrosis. And this system, stages 0 to 2 corresponded to no/mild fibrosis, stages 3 to 4 corresponded to moderate to advanced fibrosis, and then stages 5 to 6 corresponded to cirrhosis. So it provides more granularity in comparison to the NASCRN system, where you only go from stage 0 to stage 4. Here you go from stage 0 to stage 6. The study included 601 patients with biopsy-proven Nafl with the mean age of 53 years, and 42% were obese. Fibrosis stage at baseline was no to mild fibrosis in 73%, 3 to 4 in 13%, and then cirrhosis stage 5, 6, and 14%. Importantly, 37% of patients had diabetes at baseline. This was group A. 13% developed type 2 diabetes during follow-up, and then 50% remained free of diabetes. So the ones that developed diabetes were called group B, and then the ones that remained free of diabetes were group C. And the presence of type 2 diabetes at baseline or its development during follow-up were associated with approximately 2.5-fold increase in the risk of cirrhosis occurrence and the development of liver-related events. So these are some of the most convincing data on the impact of type 2 diabetes on liver outcomes in patients with Nafl. As expected, the presence of moderate fibrosis, so F3, F4, was associated with approximately a 6-fold increase in the occurrence of cirrhosis. And then if you had F3 to F6, this independently predicted liver-related events. So these includes things like ascites, variceal bleeding, and encephalopathy. Another important aspect of this study was that it provided us with the incidence of liver-related events on a yearly basis, and this ranged from 0.3% per year to all the way 6% per year in patients with cirrhosis. So I think these results have great implications for the Nafl field. First, the results demonstrate clearly that the presence or development of type 2 diabetes in patients with Nafl should be considered as an important prognostic factor that predicts disease outcomes. Those with type 2 diabetes should receive more intensive clinical follow-up to assess for disease progression. Furthermore, the prevention of diabetes development should be an important aspect of the Nafl care pathway. The results also provide the annual incidence rate of liver-related events based on baseline fibrosis stage, which will have also major implications for future trial design.
Fantastic. Anybody have a question or maybe two for Naim, and then we'll go on to the next talk? Or if not,
Stephen
go
here.
ahead, Stephen.
I do have a question. So one of the things that struck me as I listened to the presentation, and there were actually a couple others similar about diabetes. And my question then that didn't get answered, and maybe my question to you, if you have thoughts on it, if you were to break the diabetes HbA1c values into tertiles, maybe a low, middle, and high value, do you think that the more severe, the more out of control glucose patients would have increased risk for disease progression? Intuitively, I think that is the case, but I haven't really seen data to date that validates that. What do you think?
Yeah, that's an excellent question, and I think it was asked to the presenter, and he did not have the answer. But I mean, I couldn't agree more that we need to look at A1C and diabetes control. The other important aspect is how are you controlling diabetes, what medications you're using, because I suspect that if you have someone on a GLP-1 agonist or metformin, medications that we know may help fatty liver disease or at least decrease the risk of hepatocellular carcinoma, that you're going to have much better outcomes than patients on insulin or sulfonylurea. And, these details were not provided, but I suspect that the authors will go back and evaluate all of this. We need to know more about diabetes control and then diabetes medications.
Okay, so my paper was from the folks at Incitro in South San Francisco. The title is Convolutional Neural Networks of H&E Stained Biopsy Images Accurately Quantify Histological Features of NASH. The reason that's so interesting to me, I think when we first talked about diagnostics, I made this point that we talk about how AI and machine learning have promise because they can improve the coding scores on biopsy slides over the challenge that we have now, which we've talked about a bunch and Stephen has written about. To me, the even greater promise is that you wind up with a dependable, reliable, consistent, dependent measure, which means you can take all the other factors in the equation, use them as independent variables. And by running regression or certain other kinds of multivariate techniques, you may be able to pull more out of the data than you can if you have more variance. Even if you don't change the number of the score for the dependent variable, by reducing the variance, you should be able to run better analysis. And fundamentally, that's what this paper suggested. I wish they had a little more on what they did and a little less that felt like cell, but fundamentally, they took 4,600 some H&E stained whole slide images. They divided them into some 2 million tiles, about 192 millimeters squared, and they pooled them, they graded them for biopsy level features, lobular inflammation, ballooning, steatosis, fibrosis. Fundamentally, what they did after they had graded all of them was they then started running analysis on them. So one of the things they started to do was they started to pool them, group them, based on what did an individual tile seem to do a pretty good job of predicting. And then they could check for correlations between those and a variety of different submeasures. So eventually, they did all this by deriving what they described as continuous variables, which would be a distribution as compared to a single number. If one person looks at a slide, they give it a score, that's a number. If it gets 4,500 scores, that's a distribution of 4,500 cases. I assume that's what they meant by continuous. They never specified, but the results read that way. Okay, so what did they learn? First of all, they used the Ishak score for fibrosis. They were asked later why. I didn't entirely think the answer addressed the question behind the question, but for whatever reason, that score had a very, very high predictive ability. But the other three didn't really do much better in terms of median prediction than you would expect from a cross-pathologist sample, about 0.7, 0.72, something like that in all three cases. No big news there. But when they tried to lay these tiles up against each other for cross-prediction, what they identified was a really high correlation between lobular inflammation and ballooning, something on the order of 44% of the tiles that predicted one also predicted the other. And in no other case did they find a relationship of more than 8% in one case, 2% everywhere else. So by having this larger sample and by being able to pool it, they were able to establish that relationship at a level of clarity and crispness that I'm not sure I've seen very much before. Even more interesting to me was that they correlated better with the NASH biomarkers on 7 different biomarkers, but they were able to identify 2 genome-wide significant variants. They didn't name what they were, but they got 2 of them. They said they had several other suggestive relationships, and they said that when you took the scored slides, and they were all scored, I believe, by a single coder, none of those relationships rose to a level of significance. Their conclusion was that with no improvement in basement prediction over cross-pathologist judgment, you can get clearer relationships and the ability to determine new associations, which they said we could use to understand the disease better and also to evaluate drug candidates. That all makes sense to me. In fact, it goes back to what I said, I believe, when we started out down this path, which is that the simple ability to reduce variance and improve consistency using AI and machine learning should enable us to understand the dynamics of the disease a lot better. And these are the kind of results that suggest that you can do that you can make that work. And when you take a look at some of the other presentations today, like the one that Stephen's going to be talking about, which suggests that there are real threshold moments in the disease, then the ability to understand dynamically how do you get to the threshold, and more than that, how do you keep people from getting to the threshold, becomes tremendously valuable in drug development and patient care. That's less than 5 minutes, I think, but that was my paper, and I was really I want to learn more about it in the whole topic, but I was pretty excited by the result. Okay, Donna, I think you're next.
Roger, I'm happy to go next. This is Donna Cryer. I think it makes a very nice follow-up because we were both interested in the subject of AI and machine learning and how this could improve the quality of interpretation of histology as well as risk stratification and prediction. And so I also want to make sure that this is delivered and viewed in context, because as I watched sessions over the course of the day, the potential role for AI in improving the quality and our ability to navigate all of these different types of non-invasive technologies and biomarkers and such, both in research and practice, just prove more and more important, even to the point of when we got to Mary Manella's really lovely summary as part of the EASL Studio sort of end of day show. So what I chose to look at today and to start the day with was AS098, machine learning outperforms existing non-invasive tests as screening tool for liver fibrosis in the general population. I think a couple of things intrigued me about that. Certainly, machine learning, anything purporting to outperform anything else, certainly. But the fact that they were looking at general population, I want to give a nod to my fellow patient advocate, Wayne Eskridge and the Fatty Liver Foundation and his son's study and his insistence on going out to the general public and doing screening. And, with all deference to some of the trialists and folks on the phone, the speed at which he was able to screen a number of folks, I think probably makes him one of the most effective CROs around. But this particular presentation and abstract by Dr. Sierra Burrell as lead author from Barcelona Center for Research in Health and Economics, as part of that overall session on Nafl and non-invasive assessment, looked at 6 prospective cohort studies, 5 in Europe and 1 in Hong Kong. And I think that mix is very important as we looked at European and Asian data together, since we know of the differences in how NASH is often expressed differently in those geographies. And so there was a lot of discussion about the number of variables that they considered and the algorithms that were applied to this. But at the end of it, there were 6,199 patients with a mean age of 54.7, more than half women, and they surfaced 343 positive cases out of there. And so their conclusion was that their machine learning had a higher rate of accuracy than FIB4, for example, as we've started to discuss, and some other measures. But to me, the major takeaway in their conclusions was that all of this fancy stuff might not really be the answer, but it might only prove to validate that something as simple as abdominal perimeter might have a similar predictive value. So it was fascinating to me that such a very high-tech approach produced a very low-tech solution or recommendation that I think is frankly what we will need at the end of the day if we're thinking about scaling NASH screening and interventions and treatments across the world. It also, as I sort of draw that thread, as I close on these thoughts, to some other presentations that did talk about AI and machine learning and analysis of various non-invasive tests. The question of how sampling error could be corrected is an interesting one for me. that was maintained in another presentation. So, is sampling error going to be still the remaining limitation to this, even if we fully engage machine learning? What I was very hopeful about by the time the day went on was how increasingly strong the evidence and the statements about our need to, but also the directions of how to move beyond liver biopsy and to non-invasive tests was made so clearly by so many speakers. And so if we can add on top of that AI or machine learning to increase the reliability and applicability of those non-invasive tests, I think that's a really positive move forward.
Donna, this is Peter. Vlad Ratzu also mentioned in a presentation I listened to about machine learning and reading of liver biopsies potentially decreasing the sampling error. And he didn't have any understanding of why that might be, but you mentioned it also. In the talks that you heard, did anybody come up with a way, mechanism by which that would occur? Because you would assume that your sample is there. So how would just using machine learning reduce sampling error? I wonder if anybody gave any thoughts on that.
Exactly, Peter. That's why it remains a question for me that I didn't want us to gloss over on the way there. I understood fully how the intra-interpreter variability can be smoothed out, but that question of sampling error stuck out to me as well, and I had not heard an answer to that.
Let me try.
To me, that's fascinating. Go ahead, Roger.
Okay. Or Stephen, you want to go first? Go ahead.
Yeah, let me chime in on that. So it may be a matter of wordsmithing. So sampling error in the truest form is one segment of the liver is showing something completely different than another segment of the liver at the exact same time, as Vlad showed in his now historic paper of a 40% variance in a liver biopsy done at two different lobes on the same day. Uh-huh. So what I see happening with fully quantitative analysis of collagen, for instance, something that can be done today, uh-huh, part of this AI machine learning pathway, is that it gives us a more granular drill down picture into the collagen content that's currently seen. Because as Vlad pointed out in his lecture, there's architectural description of collagen, then there's collagen content, and they're not the same, right? So we can stain with Sirius red the collagen content. We can look semi-quantitatively for the architectural description of collagen and get two different findings. And I think where we will be able to bridge, and this was actually a comment that I had for the liver biopsy panel, but I don't think, unfortunately, it was asked, and that was, can we go to the FDA and say, look, while we're gaining the knowledge around non-invasive testing, can we use fully quantitative analysis, this AI machine learning technique, as a bridge between standard semi-quantitative histopathology and non-invasive testing? Because I think that is the incremental next step we need to take to propel us with a much more rapid trajectory towards non-invasive testing.
I think we can and we should.
Yeah. So this is a naive question, I think, but what AI does have the ability to do by reorganizing samples and random replacement and all these other statistical terms, is to bulk up knowledge within a sample set. The sampling error that you described, Stephen, if the unit of analysis is a liver, it isn't going to help with that. The question I was kind of wondering this morning, and I'm wondering a lot more now, is if you had tremendous variability in two lobes of the same liver on the same day, and you found an efficacious way to improve that liver, will that show up if you take another biopsy 12 months later? Or is that a third random event, if you will?
Well, I think it's hard to say. I would be hopeful that it would be able to show up 12 months later. And I think as our drugs improve, that should also improve.
Yeah, because if over a larger population it will show up, then you can wash out an awful lot of sampling error with some statistical techniques, even the kind you're describing with some statistical techniques. But you'd have to be confident that 12 months later, if you had a better result on the liver, it would show up in every place that you looked, or in enough of the places that you looked, that you could wash it through. And I don't know the answer to that question.
I mean, I think, what's clear is that histology is limited, and there is a need in the field to move beyond, but we need to get to a point where we have something that's trusted and reproducible, that you can use to follow disease progression and regression. So no matter what AI technique, we're going to be limited because the disease is heterogeneous and the biopsy is still a very small sample from the liver. I think the other area for AI is to unleash its power on large data sets and EMR systems to increase awareness. Because every time we looked at high-risk populations, patients with obesity, type 2 diabetes, when you look at ICD-9, 10 codes diagnosing Nafl, NASH, liver disease, awareness is in the 3 to 5% range. And once we have an algorithm that's developed, validated in multiple cohorts, I think this will be very helpful for the field, especially when we have FDA-approved drugs.
Okay, good. Next speaker.
I'll go next.
Peter, you're next on the list, actually. Well done.
Oh, okay, very good. I listened to a symposium rather than a single presentation in order to report back to the group. And it was on optimal endpoints in NAFLD clinical trials. And it was basically, the question was to biopsy or not to biopsy. And it was really an all-star cast with Manal Abdelmalik kind of help chairing, along with Matthias Eskart. And Matthias talked about the patient situation. And then Rohit Lumba talked about the non-invasive tests, and Vlad Ratsu talked about biopsy. And they did it sort of in a sense of counterpoint. But the fact is that a lot of very interesting information came out of this. And I'm not going to, point by point go through what they all presented, but just a couple of high points from my standpoint. So first of all, Matthias really presented beautifully all the data on the fact that reduction in fibrosis improves clinical outcomes in patients, and it's directly, the degree of fibrosis is directly related to patient outcome. And he went through that. We've talked about that before. Most people know that. He threw in at the end something that I think most people don't think about, and that is that if progression of fibrosis predicts outcome, does regression of fibrosis improve outcomes? And I know that most of the field would snap say, well, of course. I mean, if progression, the reversal is going to make it better. But in fact, that is a question the FDA struggles with all the time. So we don't really know that because we don't have any super effective drugs, and we can't do large enough trials with something like bariatric surgery. But that was an important part. And then Rohit Loomba brilliantly described all the non-invasive tests, as well as his favorite MRI, PDFF, and MRE, and how it's very clear that these invasive tests are related to changes that occur with drug therapy. I think in order to validate one of these non-invasive tests that could be used in clinical trials, you really need both things. You need to prove that it is predictive of clinical outcome, and then that reversal of that test is associated with improvement in clinical outcomes. I just want to highlight the fact that with all the data that Rohit and others around the world have generated for the importance of non-invasive tests and how everybody feels confident of that, he and the Goldmine consortium is really doing what is necessary. They've initiated a longitudinal international multi-center imaging study called the Goldmine Consortium, where they're enrolling up to 1,000 participants with both cirrhosis and non-cirrhotic NASH. And they're looking at, and they're doing all the non-invasive imaging tests, MRE, MRPDFF, elastography, as well as multiple lab tests. And they're following these patients for outcomes. And this is a 10-year study, so it's a long study. I'm not exactly sure where in the study they are, but the point is that they're doing the right thing to show that how outcomes relate to these tests. But it underscores what many will be disappointed in, and that is that you need studies like that in order to come to the conclusion that these tests are related to outcomes. And then, of course, the next step is to have a drug that significantly improves these tests to show that reversal improves clinical outcomes. So the good news is the field are doing the right things. The bad news is it's still going to take time to sort that out. And I would only make one comment about liver biopsy, and that is that Vlad again did a brilliant job of saying why we still need liver biopsies. But he also acknowledges that he would like to see non-invasive tests replace liver biopsies, but he doesn't see them going away anytime soon. One final comment, and that is when you think about drug development, there's a difference between phase 2 and phase 3. And in fact, that was brought up in the question and answer period. What you determine in phase 2 is an endpoint that you feel comfortable with moving to phase 3. That doesn't have to be the same endpoint. And it's the phase 3 endpoint which is the most critical for getting drug approval, as everyone knows. And biopsy is here to stay in phase 3 for some time to come. And number 2, there's still the issue, which was brought up during the discussion, of clinical outcomes versus biopsy measures of a reduction in fibrosis. The entire field desperately wants, and rightly so, to have reduction in fibrosis as a regulatory endpoint. But there's still a lot of concern in the area that the agencies are not necessarily on that same page. So that's, it was a fascinating discussion, didn't add anything that was great hope for the next year or so, but really a superb presentation. And I know others on this call were at that presentation as well.
I agree, Peter. I think it was a really excellent summary as well as phrasing and challenging of some of the issues. I will admit that as a patient and patient leader, I do struggle with both my understanding and commitment to clinical research and my extreme personal and professional aversion to biopsy. And so my heart always drops a little bit when I hear about 5-year time ranges or, continued need for, biopsies, at least in the NASH space. I know there will always be liver diseases in some circumstances where biopsy will need to be, available. But anything like the gold mine effort that can really accelerate this is, to be highly encouraged, I think, because from the patient point of view, it can't happen soon enough. I can't, it's very hard for me to, in good conscience, recommend that, patients continue to get biopsies in the future, knowing what the alternatives are for available, and particularly when that point of equipoise, is tipped in a different direction, and it's really only for the benefit of research. And so I want us to be very, very clear as a field and clear certainly from a regulatory standpoint in terms of at what point will we have enough evidence? What is the threshold at which point we are satisfied that there is one or a combination of non-invasive diagnostics that is sufficient to replace biopsy? I want, increased clarity around what that marker is so that I know when we have arrived.
Right.
And
no,
I don't see that yet.
I'm completely with you, Donna. And while I don't have experience on the sharp end of the needle, I've experience on the other side. And I've been in liver disease for over 40 years. And right from the beginning, when I did my first liver biopsy, I felt like we have to replace this with something. Everybody I know throughout my career wants to do that. The real issue is I think we are now through gold mine and that type of thing, going through the rigorous process that's going to be required to give everybody, and including the agencies, confidence.
Peter, don't you think that the burden placed on us, at least for conditional approval, to show histologic outcomes based on repeat biopsies is very high compared to what we've done in hepatitis C, for example? Initially, the trials were based on improvement in ALT. Then we had PCR, but we didn't really show that treating hepatitis C can decrease overall mortality up until a few years ago. And that was mainly in F3, F4. And now it's clear that, you need to treat all hepatitis C patients. But I feel like, what we're being asked for conditional approval is very difficult to achieve, and patients are struggling with no alternatives.
Yeah, Naim, I think that's a very good point. I think the one big difference is, hepatitis C is a viral infection where you can look at viral load, and you can assume that if you decrease the precipitating factor, the virus, that you're likely going to have a beneficial effect. So in NASH, it's a little bit less clear. Fat, for instance, I don't think has the same level of evidence as a viral load. So I do think that plays in people's minds when they think about it. But I do agree that the burden being placed on approval of NASH agents is quite steep.
Peter, can I just ask, because I was obviously at that session as well, and it was stimulating to say the least, but I think Matthias also brought up the point that it was the patients without NASH that actually had the highest liver-related mortality. So at the moment, all of the endpoints are about the resolution of NASH or a one-stage fibrosis reduction. Are we actually needing now to look at a different outcome?
Yeah.
If the
I'm glad
mortality is higher elsewhere.
Yeah, I'm glad you brought that up. That was another point that I didn't think I had time to bring into this, but I'm glad you asked that question, because what he was saying is that it's from data that he presented, it's clearly uncertain right now whether the endpoint of a reversal of NASH with no change in fibrosis is a good endpoint for clinical trials, whereas the reduction in one stage in fibrosis without change in NASH he does feel is a good endpoint. Yeah, that was a very interesting discussion.
And I think, this is Stephen, I think there was that's been, one of the concerns we've had for a little bit, is this notion of NASH resolution. And the thought has kind of always been that if you can improve liver cell injury, decrease liver fat content, that the only reason the liver is in the situation it's in from a fibrotic perspective is because something has initiated a wound healing response, right? So if you can shut down those processes, liver has an innate ability to resolve that, just like the skin does. So I liked how Vlad kind of came back on that a little bit by showing data from Beth Brunn and the NASH CRN, looking at the integrated database from both the Pivens and the Flint trial, showing that fibrosis improvement was directly linked to NASH resolution, NAS reduction, ballooning improvement, Mallory-Hyland and portal inflammation. But at the end of the day, if there is such a problem with pathologists agreeing on what NASH resolution looks like, and specifically ballooning degeneration, the simple thing here is to consider just pivoting to fibrosis improvement, because if we believe NASH resolution leads to that, then in theory, we should have fibrosis improvement. Now, if you look at drugs like semaglutide, for instance, at least from the data that's been reported, they're hitting on a very high rate of NASH resolution, but not with fibrosis improvement. So that notion doesn't bode well for something like the GLP-1 that's been presented, at least in a press release. And we're anxious to see that data at AASLD, not at this meeting. But so more to come there for sure. And that may be where this artificial intelligence gives us that a little bit more information for either one or both of those endpoints.
Yeah, I think those are good points, Stephen.
Okay, Louise, go ahead.
I chose to do two today, if I remember correctly, and I'm actually going to start with the second one first, because it was actually a presentation, and the come back to the one that was earlier in the afternoon, which was actually a poster recording. So the first one was AS160, which was a multidisciplinary approach to non-alcoholic fatty liver disease and Nafl, improves cardiovascular risk factors, and it was presented by Anna Mantovani and the team from the Royal Free, I think, from that perspective. And what they basically wanted to establish was, does the efficacy of an MDT approach for patients in Nafl help control metabolic comorbidities? So they studied 273 patients prospectively through a referral pathway, which I think is the Camden and Islington referral pathway, which ties to the next session that I'm going to review, with FIB4 and ELF. So they were referred straight through, or a GP decision, to a multidisciplinary Nafl MDT. So it was a real-world care situation. They received diabetic counselling. They saw a hepatologist. It wasn't clear, however, how they were identified to go into the two dietetics packages. One was 4 appointments and yearly review, and one was a one-off appointment assessment followed up by a dietitian at 3 months and then discharge back to the GP. But they took a series of anthropometric measurements, BP, FibroScan, bloods, and the Q-RISK-3, recorded them at baseline and at least one follow-up visit. But the majority of patients, she was clear, was seen over an 18-month period, and they discharged very few. So their key findings, ultimately at baseline, 93% of patients had a BMI of greater than 25. 67% of them had hypertension, 50% had type 2 diabetes, and 93% had dyslipidemia. Of all of those patients, 98.2% received a FibroScan, which is actually, given the BMI size of those patients, a really high rate of success, because I think in that portfolio you're talking about anywhere up to 35% failure rate, so their success rate was excellent. And 33, nearly 39% had a FibroScan of over 8 kilopascals, and 14% of the patients had a Q-risk-3 score of greater than 10%. Greater than 14, and 10% of that population had a high risk, 62.7% of that. But what came out of it was that 19% of the patients were poorly managed from their hypertension, 42% were suboptimal for diabetes, and 25.2% were suboptimal from their dyslipidemia. And basically the corrections that were made were to correct and better manage those conditions by the hepatology team, or the MDT, which significantly improved the AST, the ALT, cholesterols, LDL, and the systolic and diastolic blood pressure, with a Q-risk-3 score improving. And what they forecast was an average gain of 3.5 years estimated on that Q-risk score reduction. So whether or not it told me much about the management of Nafls and how Nafl's effective or improved by better MDT management, what was quite clear, I think, was that patients are suboptimally managed in a high degree before they even get to secondary care. So that's a location of opportunity, if I look back on that paper. And they quite rightly felt that they needed a stronger MDT management of Nafl is effective in improving the cardiovascular risk. Whether it improves the liver-related risk, I wasn't clear on. But a further strong collaboration between primary care and secondary care is essential. So when I thought about what did it give me about the understanding of the disease, it wasn't so much about the fatty liver disease that it highlighted to me, but it was about the actual lack of management to a high level in some of these patients, and it makes a big difference. So if I was looking at patients, it's a fact of trying to become more aware of your own condition and how it should be managed and where you can help optimize, because assuming that primary care physicians always have the time to do that isn't always right, and they just don't sometimes. And I think that study did that, but I think it does allow to strengthen an MDT and direct relation and liaison between primary care and secondary care. I think the fact that all of those patients were referred through a pathway to secondary care specialist assessment to get a FibroScan, for example, from my perspective, means that on the whole, that's a £450 appointment, because it's a highly specialised multidisciplinary group. So it's very costly. So bringing that further forward might give opportunities for cost-saving initiatives. And I think it led on to the poster that I reviewed earlier on in the day, which was FRI 016, and that was presented by David Harmon and the team from Oxford, and it was entitled "Patients with Non-Alcoholic Fatty Liver Disease referred from primary care have a significant serum marker liver stiffness measurement discordance." And what they did was use the same pathway: high ELF of greater than 9.5, high risk Fib4 of greater than 2.6, 7 and 8 kilopascals as their level of concordance. So when the levels were high, but the FibroScan was less than 8 kilopascals, they defined that as discordant. So they took a look at a series of patients. And it was, I think, 129 patients were sent through the pathway. of whom 119 had FibroScans. So again, an excellent rate when you get to specialist scanners of 92% success rate to get those scans. There was an elevated liver stiffness in 63.4 of the FIB4 and 56 in the ELF categories. So there was a level of discordance in that. And I think what came out of the results of those patients was, apart from the 56% correlation with ELF and only 63.4 in FIB4, that when they did it in an elevated stiffness of 10 kilopascals, overall throughout the there were 54.2% concordance. But they biopsied 28 of the patients that were concordant, and 60.7% had F3 and higher. Where the patients, and there were only 4 where they didn't agree, who had biopsies, only one of those patients had F3. But what was, from a perspective of new patients coming through a referral pathway, is that 31% of those patients were diagnosed and confirmed with having cirrhosis, and 54.3 had advanced fibrosis. So in that pathway, 85.7% of those patients being referred in actually had high fibrosis or cirrhosis. Significant factors of concordance were type 2 diabetes at over 50%, 14% obesity was 72.6% versus 51% non-concordance. And it is the AST, ILC 36 to 90% of these patients. So the conclusions was that there was a high discordance between the primary care and liver stiffness in these groups coming through the pathway. But there was no cap involved in the FibroScan assessment. So there may be an element of cap that could explain some of that discordance. But a referral rate of nearly 80% of patients coming through a pathway who already have advanced disease is, from my perspective, looking at the study, an unsustainable management problem, both pre-COVID and probably now post-COVID. So those were the ones I took away from that. And I think it was summed up later on in the day when they looked at the pathway that was being used on both of these studies, in the context that if you only identified patients with the FIB4 and the ELF through this pathway, the ones left outside the pathway was 4 times greater. So it doesn't pick up the number of patients that need to be going through these pathways. So we're missing a lot of patients going through, but I would have loved to have seen less rate of cirrhosis and fibrosis coming through these referral pathways, because can we cope with that literally tsunami of those type of patients coming through? So brings us back to the ELF that, FIB4 that Stephen started with a little bit earlier on the introduction. So those were my 2 papers in the practical setting, just showing, from my perspective, how high the rate of patients coming in with advanced diseases, even when we're missing with the markers quite a lot of tests. But I would have liked to have seen CAP in a lot of the studies used today, rather than just kilopascals, to try and tease out some of the steatosis levels. So that would just my personal papers for today.
And those are 2 great abstracts that were discussed for sure. Just a comment on the last part that you had there about CAP. CAP above 280, CAP above 300 really does a very nice job of predicting MRI PDFF greater than 8 and 10% respectively. And the screen fail rate on clinical trials when using those parameters are somewhere between 15 and 20%. So the converse is about 80 to 85% accurate. So the only caveat I have about that is a recent discovery that we've made, and this is anecdotal, and hopefully we can submit this as a late breaker to AA. In the setting of cirrhosis, we're finding false positive CAP elevations. In fact, the only reason this came to light is because, again, a finding that happens in clinical trials, but not something that's done in routine clinical practice. And that is, we are pre-screening people in clinical trials with FibroScan and CAP, as well as KPA. And then if they're above a certain threshold, i.e. around 300, they're eligible to move forward to an MRI PDFF, where the requirement is 10%, and then they go to a liver biopsy, or they have a historical liver biopsy showing cirrhosis within the past couple of months. Well, here we're able to correlate PDFF with CAP, and we're finding that it's nowhere near accurate. In fact, I don't have the numerator and denominator yet, but there are a significant number of false positives where the CAPs are all above 300, but the MRI PDFFs are all below 7%. And often many times below 5%, suggesting no steatosis whatsoever, which is what you would expect in a burned out NASH patient with cirrhosis. So I think there's going to be some more data coming on the cirrhotics with CAP, but absolutely I think it's a spot on comment for the non-cirrhotics.
Do you think you retrospectively do FAST score in the study that you're talking about? It's anecdotal.
We're not doing FAST retrospectively in that particular trial. FAST is gaining in popularity, but we're not using it for that particular study. Where we're beginning to look at FAST, in addition to identifying NASH patients with NAS as a 4 with F2 or greater fibrosis, which is as described in the paper we published in Lancet, is we're beginning to look at the delta change in FAST to predict outcomes. Not long-term outcomes necessarily, but therapeutic efficacy to drugs. At least in the short term, that's the next step with FAST.
Yeah.
And quite frankly, probably with NIS4 as well.
Yeah. And I think when I was looking at these studies, it's whether or not, and everybody knows my views on making FibroScan that much more accessible to GPs to actually make sure the right patients are coming through the system. And with those sort of discordance levels, to wait to get to secondary care to actually find out that the stiffness isn't there. And we know the negative predictive value is quite high in FibroScan. So whether or not bringing it further upstream does make it that much more cost effective and help screen a lot more patients. And I think some of the evidence was coming out today on certainly type 2 diabetes above the age of 55 being far more cost effective now. And I think this was an interesting day throughout. So congratulations to EASL on that.
Yeah, and that's actually a great segue, Roger, if you want me to jump in.
That's perfect. Yep.
So, just to bring this to a close from an abstract perspective on day one, my task was to review abstract 100 at the early hour of 5:00 a.m. Central Daylight Time. However, I did try to engage with the Q&A to keep me going and focused. So this was a very elegant study done by the NASH CRN. It was presented by a good friend of mine, Naga Chalasani, the chair of GI at Indiana. And the study, just in a nutshell, looked at about 1,200, more than 1,200 cases where patients had undergone or were enrolled. Actually, not that many. Let me back up. So this study ultimately was targeted at following a group of patients in the NASH CRN over time, looking at serial VCTEs. And what we know about VCT, at least from the perspective of the U.S., is there's over 1,200 units that have been employed in North America, so that's US and Canada. And there is a CPT code for it. It's 91200. And it is reimbursed when done annually. So serial VCTE measurements are common. And so the aim of this study was to describe liver stiffness worsening. And a second aim was to look for risk factors for progression to cirrhosis. So using the robust data set of the NASH CRN, patients were evaluated from 8 different academic centers. And this segment of the NASH CRN database was followed from 2009 onward to, I believe, 2019. VCTE wasn't really incorporated into that follow-up until 2014, but subsequent to that, it was, and they used the older system, the 502 Touch. They originally started with the M probe, and they moved to the XL probe as the machine dictates. And that happened in about 60% of the cases where they went from the M probe to the XL probe. The screen failure, or the failure rate of that VCTE, has previously been published by the NASH CRN at 3.2%. So ultimately, the goal here was to evaluate the longitudinal change in liver stiffness and stratify that according to baseline liver biopsy stage. And then look at the progression to cirrhosis. Now here, cirrhosis was defined non-histopathologically as a liver stiffness measurement of greater than 14.9. There's also part of the trial was looking at factors that predicted this progression. So ultimately, 1,010 patients were recruited and evaluated in this study. The mean age was 51 years, 63% were men, 86% Caucasian, 40% were diabetic. The mean BMI was 34. And about 58% were definitive NASH and 8% were cirrhotic. And so ultimately, a couple other important points for baseline here. 203 patients evaluated out of the 1,010 actually had 5 or more serial VCTEs done over that period of time. The mean CAP was 312. The mean KPA was 7.6. And ultimately, the findings that came out of this are very, very succinct. Number one, only the F3 patients had liver stiffness that that worsened over time. So if you just took the F0s, the 1s, the 2s, and the 4s, they didn't really show a longitudinal increase over time. It was just the F3s that had that worsening liver stiffness. And the follow-up mean was about 2.8 years, so that may be part of the issue there. The follow-up just wasn't quite long enough. The mean change was 0.57 kPa per year. And maybe just as importantly, additional data that I thought came out of this presentation that was apropos for this conversation today was the annual risk of developing cirrhosis was 6.8%, roughly 7%. And another way, another report out from a descriptor from this trial was that 25% of patients without cirrhosis developed cirrhosis by liver stiffness measurement criteria in a mean of 4.4 years. You say that again, 25% without cirrhosis developed cirrhosis in 4.4 years. So with that, I found that was a great way to start the morning at 5 today. And I'm only hopeful that tomorrow morning at 5, it will be just as enlightening. And with that, I'll stop.
Stephen, were you surprised by these numbers? I mean, to me, they sound very high. 25% progressed to cirrhosis within 4.4 years. Was that limited to patients with F3 at baseline, or this was all comers? I mean, it's hard to imagine someone with F1 progressing to cirrhosis this fast. And same applies for the annual rate, 6.8%. Did they specify?
Well, two things here. Number one, remember, Naim, this was not our classic histopathologic natural history study. like the Stellar 4, for instance, or the Stellar 3, where we can look at 800 F3 patients and know the drug didn't work. So essentially everybody was on placebo. They had follow-up liver biopsies. This is all kind of based off of that non-invasive measurement of liver stiffness passing 14.9, and subsequently those were called cirrhotic. So it's hard to say if they were legitimately F3s that were the ones that progressed versus just maybe somebody with milder disease, but they had a sudden rise in their KPA over time. When you look at the plots of F2, it looks like it's almost, particularly the last couple of years, there's a trend upward that looks like it was going to probably hit stat sig. F4s actually have a smile-shaped curve. They started out higher, then dipped down, then climbed back up. F0s and 1s didn't move a whole lot. I think what we're probably talking about here is this arbitrary F2, F3 group that probably passed 14.9 and gave us that number. But that wasn't clearly outlined in the presentation and it wasn't addressed in the Q&A either.
When I saw the presentation, one of the thoughts I had in my adult state at 6 a.m. in the East was that if you start talking about places where better use of machine learning could help you core into the patient dynamics better, that upward curve that started late in F2 and clearly continued through F3 was one of the things you'd want to look at given the consequences. Could you envision how that would work? Is that a sensible thing to think about figuring out how to do?
Well, yeah, absolutely it is. I mean, one of the challenges that we have, and Naim and I still see quite a few NASH patients, is we use FibroScan on the front lines, and I find myself, I may be exposing something here, but I find myself using FibroScan every 6 months, not every year, and I look at these trend lines for movement, and if I see a rapid uptick, it makes me wonder about the validity of the test, but it also makes me go back and do a deeper dive into what else might be coexistent with that bump in FibroScan. In other words, I've seen a huge rise in serum aminotransferase. Is the platelet count taking a dive? Is the albumin taking a dive? Does the patient look like they're developing some early sarcopenia signs? It makes me do a deeper dive into that particular situation. Now, oftentimes, the next time I check it, it's come back down. And so I think that's the nuances of a non-invasive test that has a poor positive predictive value when taken by itself. Mm-hmm. But again, when you're able to look at it in concert with all the other clinical data, it is very helpful. And I think, the problem here is we're seeing a report of a single test rather than the whole conundrum of data, the whole ball of wax, if you will, in front of us.
Okay.
I think it was interesting because it did set off a little bit of a Twitter conversation this morning. But I wondered, when we look back at the clinical trials and obviously GEMFIT, when you look at the F0 to F2, whether or not the ability of FibroScan here to keep people in track of their own behaviour, because it's quantitative. We know it makes an effect when patients see the results, and whether or not they're starting to lifestyle manage. And I know Naim, when he did that episode, was also into the wellness issue, where you can make a difference to yourself and you're being monitored, you do. So whether or not this is that placebo effect that we're seeing, that we saw in the trials, that they maintain their weight, they can change things, and they've got quantification for stability, I suppose. Do you think that might be having an effect?
Yeah, I think it's all playing into this, I think for me, the compelling piece of this was it highlights to me the the real disparity in collagen content between an F2 and an F3 patient. We're kind of, it's drilled into our head, or we kind of have this sense of, that F3 is a little more than F2, which is a little more than F1, but it's really quite a big difference when you measure the amount of collagen in an F3 versus that of an F2. Again, something that Vlad alluded to in his talk earlier today. So, whether it's actual 6.8%, annual risk of developing cirrhosis, that number is not too far off of what we saw from Stellar 3, if I remember. Naim, do you remember the numbers from Stellar 3 progressing? Was it? I can't remember off the top of my head.
Yeah, but that was an F3 population. I mean, biopsy proven for the most part. So I think that wasn't a surprise. This is more like a mixed population, and we have data from simtuzumab also. That about 20% within 2.5 years progressed from F3 to F4. I think for these patients, I'm more convinced. F2, I'm not sure that, this annual rate is really reflecting what happens. And as you said, FibroScan has limitations, but I do the same. I check it every 6 months and look at the trends. I also use CAP score as a way to encourage my patients. And I just saw someone today who lost 20 pounds and her CAP score went from 320 to 280. And that was very encouraging for her. And she's going to continue to lose weight. So I think it's a good way to monitor patients.
Okay, great. So this has been a fantastic conversation. Covered a lot of territory. It was a fantastic day in the meeting, fantastic conversation as well. Just going around to close, the one thing that you took out of the day and this conversation that you think is going to have the greatest effect on how you think about disease? Brave one, go first.
Yes, Louise, I'll go first. I suppose it was going back to Matthias's point that patients without NASH actually have higher risks of liver-related events. And I think focusing on ability to help and change in Nafl is probably a key factor. And I think relating that to Donna's work with the ICD-10 recoding of mild NASH, how the ability to find that with blood tests makes it even more difficult, but also more pressing that we find non-invasive techniques that help us locate those patients, because they are at increasing risk if this evidence is supported elsewhere.
Okay.
Yeah, I think the search for non-invasive tests and ways to optimize also how we interpret histology continues. I think we all need to have an open mindset that, maybe the primary outcomes will be changing. I think generating data correlating non-invasive tests with hard outcomes such as progression to cirrhosis and liver-related outcomes is a big unmet need that potentially will have the impact on the field in terms of changing outcomes for good. So I think, I'm impressed to see all the updates in this field, and we continue to work on it on a daily basis.
Okay.
This is Stephen. So I think everything I listened to today, the most impactful, the bang for the buck of my time really was the liver biopsy endpoint, or the endpoints of clinical trials that has been talked about by Peter, and then we've all kind of chimed in. And I'm drawn to one slide that Rohit showed on the MRI PDFF response criteria, particularly targeting line in MRI PDFF of greater than or equal to 30% from baseline, summarizing the volume of data that's been created. That decline is linked to a 2-point improvement in the Nafl activity score. It's been linked to NASH resolution. It's been linked to ballooning improvement, and it's also been linked to fibrosis improvement. So to me, I think that may become a marker that can be used, and it may be the marker with the most data that crosses the hurdle first with the FDA for a non-invasive test. So while it's a marker of triglyceride improvement in the liver, there's so many other things that happen when you improve triglycerides, and I think it's just, while we can't detect ceramides, diacylglycerols, toxic cholesterol metabolites, I suspect those are moving in the right direction with the liver fat content lowering. So I'm going to stay tuned to that, because I think that actually was quite telling today to see that data summarized the way it was.
This is Donna. I'm just glad that this is the first day of the meeting. It's very hard for me. My legal training pushes back on drawing conclusions from partial or isolated pieces of data. It seems to me that we're still putting together the case. And I think for any patient advocates listening, it's just understanding that the road of research and science is long. Because if I just left, with my feeling this afternoon that primary care physicians don't even believe in a significant number, don't believe in Nafl or NASH, and then despite the increasing evidence, we are still going to be saddled with biopsy for some time to come, I would be discouraged. But that's not the message. It's an evolving story, so I'm looking forward to the next days of the conference to help me pull all these pieces together and really give some context to what is the significance of things I'm hearing on the first day.
So I have to confess to having no legal training whatsoever, but having had a fairly similar reaction to the day, which is that I tend to think in terms of predictive models and things like that. And everything that predicted something today predicted something different. And many things didn't predict anything. And it left me believing that there are a lot of threads that aren't necessarily going where people thought they would go, but haven't quite proven where they're headed yet. I think the testing is actually, getting aligned around testing is a big piece of it, so that we all have some common understanding of what we're evaluating and how we're evaluating it. Those what drew me to this disease in the first place. And today I think we live with today I think we see some of the impact of that. I agree with you, Don. I'm looking forward tremendously to the next 2 days. Frankly, I'm also excited that due to a quirk of fate, AASLD is only a couple of months off, because it means that whatever research didn't make it to this presentation because it was targeted to that one, over the next 3 months, we're going to have a bolus of things to think about. And I think that's really exciting as well. With that said, I think it's time for all of us to say goodbye for today. I want to thank Naim for joining us. I want to thank all of you folks, surfers, for sticking around longer. Peter, unfortunately, had to leave a little bit early, did not get a final comment, but he'll be back tomorrow. Tom McDonald, who's engineering for us this week. Eric and Polite and Ryan, my team. And all of you folks who listen. Great conference, great start. Thank you very much. We'll see you all tomorrow. Until then, stay safe, surf on. Bye-bye.